digital technologies are foreshadowing the best and worst outcomes in health and societies. Last year, for example, news reported that AI are explore or discover new antibiotics. So this is a very promising development, but at the same time, AI spreads, but also helps to discover misinformation that erodes trust and undermines science-based attitudes. And all this happens in a very rapidly changing environment. And the past year was a year of extreme heat, and humans can now feel the changes that we have fabricated. And many, and if not all, health problems accelerate given the climate crisis. And I think this is also why, in preparing the new European program of work, it is very likely that WHO includes the topic or a focus on climate and health and the consequences of our connectedness of our worlds. And therefore, we're very happy to contribute some thoughts regarding these issues and to open the discussion with you and the other collaborating centers, other researchers and partners and friends, to reach our third goal for today, to team up to support WHO and the member states in granting healthy lives for all. Next slide, please. Thank you. And we would just like to briefly give you an overview of who we are as a WHO collaborating center team. And what you can see here is the team at the Bernhard Nocht Institute for Tropical Medicine. We are located, but this is not the whole of the crew. So maybe next click. Thanks. So there is more. There are more people in the team, which is based at the University of Erfurt, where about 25 people work in the core team of health communication. And we all work under the umbrella of planetary health, which is the widest possible lens you could use to look at health. And it includes the interconnectedness between humans, animals, and nature. And this is also the area where our WHO Collaborating Center operates. And here I would like to hand over to my wonderful Deputy Director, Dr. Sarah Eitze. And thank you, Sarah, for being the driving force behind this WHOCC and your thoughtful composition of this symposium, Sarah. The floor is yours. Thanks.
Thank you so much. So as you can already see, we are a very big research group. So our research interests, our special research interests are plenty. For example, we are interested in vaccination decision-making, and also a healthy diet is part of our research profile. But we are also interested in mitigation and adaptation of climate change impact, such as extreme heat consequences, for example. But climate change also includes the fact that tropical diseases, or so-called tropical diseases, become more common in Europe, and we want to understand how we can increase prevention behavior against vector-borne diseases. Also, antimicrobial resistance is a big challenge that we need to mitigate by using and demanding less antibiotics. Of course, in every health behavior, knowledge is the first and important step to health behavior change. And we also partly focus on women's health topics such as endometriosis. In plenty of our research projects, healthcare workers and their critical role are essential when it comes to targeting misconceptions or prescribing antibiotics. And last but not least, we also are very passionate about what we do. So all of these topics are included in our 3 goals that we defined for our collaboration center. The first goal is realizing the full potential of behavioral research data. So this includes fully understanding the data that we collected during the COVID-19 pandemic to be better prepared for upcoming emergencies. But we also design surveys and experiments to understand additional topics, such as the readiness to act against climate change. The second goal is making sure that these behavioral insights are usable and can be implemented by local and regional health authorities. So By participating in the BCI Learn initiative, like we did in the Behavioral Insights Summer Schools, we hope to bring science and practice together to meet in trainings for data collection, interpretation, and using these data in interventions. And our third goal is we aim at supporting direct and conceptual replications around the globe. So most of our behavioral insights that we already have are from Northwestern countries in Europe or in North America. And we need to make sure that these are useful for intervention designs in all cultures and regions. And by replications, we test if this is actually true. So we currently work together with researchers from Ghana, Gabon, or Tanzania, and we will be happy to expand our replication projects in Africa, Europe, and beyond. Okay. Today, we would like to dive into 3 topics of behavioral insights for better health decisions. So first, Felicity Thomas will show us possible ways for reaching into target groups with low trust in institutions and science. Then John Holford will introduce us to the empathetic refutational interview approach when it comes to misinformation. Afterwards, Robert Böhm will show us evidence why antimicrobial resistance is a social dilemma and how we might overcome this behavioral influence. And last but not least, Katrine Habersaat will show us in a brief presentation how the behavioral insights that we then heard become usable in the work of WHO Youth. So how are we making sure that your voices are heard as well in this symposium? We'd like to have a discussion after each presentation. So if you have a question or an idea you want to share, please raise your digital hand after the presentation is over, or you can ask a question anytime in the chat function as we monitor this as well. And please mute your microphone while others are talking so we are able to hear everyone. Our time management is 15 minutes for each presentation and 10 minutes of discussion after each presentation. So we have a bit of time left afterwards. So our first presentation will be about reaching and researching target groups with low trust by Professor Felicity Thomas. She's the director of the WHO Collaborating Center for Culture and Health at the University of Exeter and has interdisciplinary background that includes anthropology, public health, education, and geography. And we will hear something about the intersections between poverty, mental health, and medicalization in low-income communities. She's also the co-creator of the Behavioral and Cultural Insights Hub, the BCI Hub, which is always a good source of behavioral and cultural insights evidence when you're looking for it. Okay, so with this, I would like to hand over to Felicity.
Thanks, Sarah, and thanks, Cornelia, for inviting me today. It's really lovely to be here. I'm just going to hopefully share my screen. Can you guys see that okay? Yep, okay, great. So as Sarah says, I'm going to talk today about some research that we've been doing in the UK with communities where there's very low levels of trust. I want to start with a quote by the historian Geoffrey Hoskins, who says that human beings are by nature trusting, though not infinitely so. So in seeking to strengthen trust, we're working with the grain of human nature, but we also need to recognise that once trust is broken, distrust takes over forcefully and cumulatively. When it becomes widespread, it's extremely destructive. And as has already been mentioned today, we hear a lot today about this kind of crisis of trust in politics, in the media, and in the systems and structures that are set up to provide services to us. And of course, that includes healthcare. Now, whether or not there's a crisis of trust is debated, and to what extent that crisis really exists. But I think Hoskins' quote here is really important in that it doesn't just talk about trust, but it talks about the opposite, as in distrust, and how this can impact really negatively on people's experiences, particularly in health and healthcare, once it actually takes over. And why does trust actually matter in health research? Well, first of all, we don't really know enough about the needs and priorities of the people who whose trust in health systems and processes are low. And a lot of the time, we get medical research where a lack of inclusion has really skewed our understandings. We'll know that there's skewed data around gender, around race, around socioeconomic groups, and so on. And very often, it's those people that don't have the trust in health systems and processes, they're marginalised populations and groups, but we don't know enough about what's going on for them. And this can not only create, but can also exacerbate health inequalities. Those who lack the trust, often those who could potentially benefit the most from the systems and processes that are in place to support them. But to be able to move on in a constructive way, we really need to be able to understand why people lack trust in the first place and how health systems and processes need to adapt or change to support people's needs and priorities in this space. So I'm going to talk today about a couple of examples, if there's time, where we're building trust within the research process has been really critical to ensuring that we're understanding the nature of the problems that people are facing and the ways that they feel that these problems can be addressed in a way that they feel would actually help re-engage them with health systems and services. So the first example is around mental health in low-income communities, and then if there's time, I'll also talk briefly about child protection and family welfare. So you can see on the screen here the levels of antidepressant prescribing in England. You can see they've risen massively over the last few decades, from under 20 million in 1998 to almost 90 million items prescribed in 2023. And this isn't unique to England. This is a fairly typical kind of graph that you'd see in many countries, many developed countries across the world. Now, we might see this as a good thing if it means that people who need medications are actually receiving them. But if you look at the map here, so it's a little bit blurry, but what you can see is the red areas are areas that have particularly high levels of antidepressant prescribing. And this is a little bit old, this map, but the data that we've got, the more recent data shows that it's the same thing that's still going on now. So where you see the red areas, they tend to be socioeconomically disadvantaged areas of England, post-industrial areas and areas of coastal deprivation. And in Blackpool, up in the north here, 1 in 2 adults are prescribed antidepressants. And we're seeing that these drugs are often taken for longer periods of time than ever before, with around half of people using antidepressants now classed as long-term users. Now, much of the evidence around antidepressant effectiveness is based on studies with people with severe depression, and this is something that's very often not made clear to patients. Those patients in primary care, where this prescribing generally takes place, are actually in the mild to moderate group, mild to moderate range for depression, for which evidence suggests a low effect size, meaning that for the vast majority of people, antidepressants are unlikely to be of much benefit. And this matters not just because people may be being given unhelpful medications, but also because there's a potential for harm. There's a lot of evidence to suggest potentially harmful side effects, including emotional blunting, weight gain, insomnia, decreased libido, nausea, and so on. And there's also known problems with withdrawing from antidepressants as well. So they're not a completely neutral medication that's being given out here. Now, when I first got interested in this subject, which was sort of about 10 years ago, I guess, there was a huge amount of rhetoric around about poor people and what we call working class neighbourhoods, and the people within them have, for a very long time now been the subject of public scrutiny and judgment and media scorn. And this is regardless of which political party is in power at the time. The narratives that are used to demean the poor in politics and popular media have been incredibly undermining, seeing people as dysfunctional, feckless, lacking in taste and morality. And there's a huge amount of shaming, which has helped governments to bring in quite punitive changes to welfare entitlements. Like I say, the examples here are a little bit old at this point. I don't know if anyone here has ever seen Little Britain or Shameless or Benefit Street, but they were 3 programs that were around in the UK a few years back, which were really influential in kind of spinning this narrative about poverty and blaming people for this. So when you think about this kind of stuff, it's not surprising. There's often very low levels of trust in poverty-affected communities. And this affects all aspects of people's lives, including the ways that they interpret and represent their own health problems, and also the ways that other people, like doctors, respond to them as well. So I want to talk briefly about the De-Stress Project, which I ran between 2016 and 2019 in the first phase. And this aimed to understand how poverty impacted on mental health in low-income communities, how people were experiencing healthcare when they approached general practitioners about their mental health, and how doctors experienced working with low-income patients whose problems were usually caused by socioeconomic circumstances rather than medical issues per se. Not much time to talk about the findings from the project. You can see more on the website if you're interested. But the headlines from the research were that rather than helping patients experiencing poverty, most people being prescribed antidepressants talked about this as a very disempowering and undermining experience. Many people reported poor side effects and difficulty stopping the medications. And at the same time, we found that doctors were also conflicted and unsatisfied when they knew that what they were doing in terms of prescribing wasn't of any real benefit to their patients. They usually didn't know what else to offer, but they just wanted to be seen to be attempting to help. You can see in the quote at the bottom here, the GP sort of saying, well, we prescribe things like fluoxetine. It's a sort of fairly safe, fairly clean drug. It won't do very much harm. We kind of know it's not going to work. There's not much evidence for it, but we still do it anyway. Even though actually, lots of patients were saying to us, we're being prescribed this stuff and it is harmful to us. So in terms of the project, it became really clear to us very early on in the project that we needed to build trust with and work closely with the people affected by the issues at hand. So people living in low-income communities who are experiencing poverty-related mental distress. And there were various ways we went about doing this. We had sustained involvement with community partners right from the very beginning through inclusion on an advisory board, so steering and guiding the project all the way through, helping us write documents and recruitment materials, supporting local recruitment and building trust within communities, helping to analyse data, and that also meant arguing with us and kicking back on our interpretations of what we were finding and making us expand our minds in the way that we were looking at our data, and that was really interesting and important. Identifying ways to disseminate the findings so that they weren't just in academic journals when nobody ever reads them besides academics, but actually how to make these findings useful within the communities that were at the heart of the research. We also did play the academic game too. We did some joint publications with our community partners and joint conference presentations. And in the second phase of the project, we actually moved on to training GPs. So you can see in the photo here, this is some of the research team and some of the community partners, but by no means all. So from 2021 until now, we've been working with our community partners to deliver training to GPs across England. Community partners have been involved in the training team, working alongside a GP and a researcher to sort of help identify and test key messaging where GPs can adapt what they're doing in consultations when they have a patient come in with poverty-related mental distress. The community partners have been fully involved in all aspects of this. They've been involved in some of the filming for this online resource that we've developed. They've developed a mock consultation. They talk about their own lived experiences and sorts of film clips of that. There's also been involvement from health professionals. It's been piloted with over 800 primary healthcare professionals across England, and follow-up with low-income patients who've received the adapted consultation put forward in the training has all been really, have received really positive feedback from both healthcare professionals and patients. It's been accredited by the Royal College of GPs, and it's freely available across the UK now. So that's a sort of example of some of the work we've been doing together with our community partners. And at various stages of the research, we've said to people, why have you stayed involved in this? Because it's a long time to be involved in a project. And some people have come and gone, or they've dipped in and out when they've felt that they've got other things that they need to be focusing on instead. And that's all absolutely fine. And I think flexibility has been part of what's kept people involved. But really the main issues that have emerged is that people see that this is an issue that they really identified with and they wanted to see changed. And we spoke to people right at the start, before we'd got any funding, about what are the issues? How can we approach this in a way that's going to make sense? All the way through, people said they feel listened to and taken seriously. They can see that their perspective on things gets followed through in our actions as a research team. They talk a lot about the flat hierarchy within the research team. No one's sort of more important than anybody else. Everybody's voice is really important here. Individual support has been absolutely critical. It sounds really basic, but when you work in a UK university system, actually trying to get our systems to be responsive to people's needs is incredibly difficult and incredibly frustrating. But things like making sure people get paid in ways that work for them. It might be vouchers that can be used locally, rather than a voucher for a shop that is 20 miles away when people don't have a car. Helping people to get to places where they need to be. Having things paid for in advance for them so that they're never out of pocket. Regular one-to-one keeping in touch to make sure that this is how people want to be working and what works for them and so on. And also peer support, weekly drop-in sessions, which still continue to this day. So there's this peer support group, which continues to meet every Thursday evening. And we have a community connector role, which helps to facilitate that. And it's been absolutely critical for our community partners to work with us and to develop trust with us, but also amongst each other as well. And they actually made a film, there's a link to that here, which talks about their experiences and what they've really benefited from in this research and why they've stuck with it, essentially. Just really quickly, I know I've only got a couple of minutes left. I just wanted to talk really briefly about another example, which is around child protection and family welfare, which again in the UK, we have an incredibly high association between poverty and child removal rates, really low levels of trust in these communities, where people have had high child removal rates, active avoidance of formal services. And what we've seen in the UK is budget cuts, which means resourcing for supporting families at an early stage has been limited. Problems are escalating to crisis point and more child removal is taking place. So child removal has really escalated in the last decade. And what we see is people experiencing repeat child removals, and those people are seen as kind of nobody's responsibility. Nobody is then responsible for helping those people. What tends to happen is that they sort of get stuck in a cycle where they are facing things like domestic abuse, substance abuse, and so on. Nobody's supporting them. There's repeat pregnancies and repeat child removals. Just keep on, it's a sort of cycle of problems. What's worked here, again, we've had a community connector role. Somebody's been based in the community supporting those individuals. We've also had an embedded researcher role, which has been really critical, and that person's been based with the local authority, gets to sit in on the local authority meetings, and helps to it's a good feedback loop between the community and the local authority, but it also really helps understand what the limitations of the local authorities are too, and the boundaries that they have to work in. So I think very often as researchers, we don't always understand that. And it's very easy for us to criticise without really understanding the constraints of those roles as well. So it's acted as a really good bridge between parents and services. It's been a helpful conduit to feedback different perspectives and start conversations. We've also involved community sector and voluntary sector groups within this. And out of this has come the Breathing Space Service, which is a new space in the southwest of England for supporting these parents who've had repeat child removals. We've managed to build this trusting relationship with the service team. There's also a sort of peer support group in place there to help reduce the shame and isolation for these parents. And the parents have just worked together with the local authority to produce a film about their experiences, both to help to educate social workers and to encourage other parents to enrol in the service. So just some final thoughts. Obviously, research with target groups for trusted those is really critical to understanding people's needs and priorities and addressing health inequalities. Extractive research, where people just sort of parachute in and out and take data without ever giving it back, they often exacerbate distrust. We need to find ways of communicating and working that unsettled conventional power hierarchies and enable people to feel respected and heard. Building trust takes time and is labour intensive, and that has to be factored into research thinking and funding. We're starting to see some of that, but probably not enough. I'm sorry, I realise I'm over time, so I'll shut up. Thank you.
Thank you so much for this really interesting presentation and for all of these insights from your very special target groups, actually. And maybe I'll take some time to see if someone has a question here. If not, I think what I thought was, there is a question. Yeah.
Thank you for this presentation. I think it illustrated one principle that also during the 45 years that I was working in a community health center in a deprived neighborhood in Belgium, that we experienced this. It's about building relationships, and relationships on a basis of not superiority, but just being a partner. And that means that you are part of the local community, that you understand what's happening. We had a practice with people coming from 95 different countries, so every consultation was a journey around the world. But nevertheless, you can build relationships with people, and that's the basis of all next steps. And I think we should invest more in that. And these relationships are, of course, structural, that you have access to care, but are also psychosocial, that you absolutely have not a relationship of power, but that you have a relationship of equitable interaction and looking together for solutions and finding the smaller step that is acceptable, feasible, affordable for the person in front of you. And what I learned in those 45 years is there is always a smaller step that you can go together. And I think that that's very important when it comes to training of professionals, and you mentioned that as well, that we can give them those experiences in real life. That means train them in those communities, bringing them there, and helping them to experience their power in relating to others.
Thanks, Jan. Yeah, absolutely agree. And I think none of what I'm saying is kind of rocket science. It's all such of basic stuff, isn't it? That relationship building is absolutely critical. But and I don't know what it's like in Belgium, but in the UK, there is a shift towards recognizing the need to work in this way, but it's not necessarily being followed in action by our research funders. There's a little bit of a shift by some funders, but we really need to have it recognized much more fully than it is at the moment. And there are still people being given huge amounts of money who don't do any kind of community engagement at all to do their research. And then it's not surprising when things don't work or nothing changes. And it gets really frustrating when, we all kind of know this, but nothing's changing. So yeah, thank you for those comments. It's really nice to hear you saying that. Thanks. Cornelia.
Yeah.
Yes, thank you, Felicity. And I just want to go on in this line and just briefly ask, so for those who, want to start the embedded research, maybe you can just, put together some do's and don'ts, the things you've learned, just on the spot. Is there, Jan already said some things, but maybe you want to add some. Thanks for your nice talk. Thanks.
Thanks. Yeah, embedded research, again, I don't know how widespread this is in other areas. It's not something that's that common in the UK. It's more common in health services research than it is in social care research, but it's still not very widely practiced. But what we have where it happens in the UK is when our research is sort of embedded normally with the local authority. And it's up to the local authority to sort of decide what the research priority is, I guess. But the researcher will have a bit more of a neutral role in that, and I think that's quite important. I think it takes a particular type of person to be a good embedded researcher. It's not me. I wasn't the embedded researcher on that project. It was a colleague of mine who has a lot of patience and is very diplomatic, which I'm not. I normally speak my mind, so I would have been hopeless at it. But I think, you need the patience. You need to know when to kind of just listen to what's being said and to hear all of those different perspectives and to really understand the constraints that the people in that room are under in terms of, the systems they have to work within, and to appreciate how frustrating they also find that. Because again, like I say, I think it's easy as researchers for us to be critical of health services and of social care services. And that tends to just get people's backs up. Certainly when we were working on the de-stress project with GPs, I mean, GPs in the UK have been so overworked in recent years. They're incredibly time and resource poor, and they've been really criticised by the general public. So they're really feeling, like they're up against it at the moment. So that, and we were critically aware of this. The last thing we wanted to do was come in and feel like we were criticising what they were doing. So I think it's about kind of finding gentle ways of making points, but also offering solutions as well. There's no point in coming in and just being critical without actually offering a way forward. One of the things that we found with the embedded research that's been really beneficial is to explain to the people that you're working with what the research can do to help them and their organisation as well, I guess, in terms of offering back data or helping with data analysis. So in the local authority where we've been doing the work with children's services and the public health team, they collect lots of data, but they don't often know what to do with that data. They collect it because they have to. There's a minimal amount of analysis done on that data very often, but those data sets are not necessarily brought together or scrutinised, and they're not maximised to the full. So we've been helping them to use the data sets a little better, to really understand what's going on in their area, and from that to kind of pull out some of the figures on child removal, where exactly it was going on. And it was very clear that it was the poverty affected areas that were most impacted in this local authority. And there were certain families where there were particularly high levels of child removal, and a very sort of long pattern of that going on. And you can help people identify where the gaps in service provision are and that kind of thing, I guess. So definitely we see that as much more of a relationship now, that it's not us as a separate university entity. We are all working together on this, and the whole local authority is now moving towards a kind of research culture. They've actually now employed a researcher as an integral member of the local authority public health team, which is great, just to see the research has become so embedded in that way too. So I think it's about mutual benefit, finding what's going to be useful to everybody and not ever coming across as being overly critical. So you're trying to be constructive, I think. Sorry, that's really vague.
Yeah, but very important. So thank you so much for your answer. Sarah, do you want to add? Oh, yes, of course, the flowers. Thank you, Felicity, for your talk, and for the audience for participation. And I think we'll move on to the next speaker, which is Dr. Dawn Holford. And we were just speaking about trust and how empathy and relations are important, and that's exactly what the next talk is about. And Dawn is an experimental psychologist, and she's one of the key figures, I want to say, in the JITSUVAX project. It's an EU-funded project led by the University of Bristol, where the team has been developing effective interventions against misinformation in healthcare professional training, especially in the context of vaccination. And Dawn, I'm very much looking forward to your talk, and the floor is yours. Welcome.
Thank you, Cornelia. So I think I can't share until this screen goes off. Okay, yes, now it's allowing me to. Great. Okay. So that should be sharing now. So
look good.
Fantastic. So yeah, thank you so much for inviting me here. As Cornelia mentioned, I'm from the JITSUVAX team at the University of Bristol, and we're a team that works across Europe. So you can see here how big it is. I think all the little stars are on the countries. Your faces are there, so I can't actually see my map, but never mind. And Erfurt is one of our teams, so you might see some familiar faces there. And so we kind of looked at how we can use features of misinformation itself to teach people to have better conversations around specifically vaccination. And so I probably don't have to tell this group why misinformation about vaccination is a problem. We know it does have a cost, And just to illustrate this, this is research that was done in Canada that was estimating the counterfactual, which is what would have happened if people had not hesitated to be vaccinated against COVID-19 due to their exposure to misinformation. And so this research was estimating the number of COVID cases that were attributable to misinformation. And of course, if you have that many COVID cases, it means a proportion of them would be hospitalized or go into intensive care. And of course, people would die. And so the total cost of that misinformation for about hospital costs only, so this is not economic or social costs that might grow from that, it was nearly 300 million Canadian dollars. And that's just to show that this is something we do have to address. But the problem is misinformation is quite tricky. It's not so easy to counter by just putting out facts. If you could do that, we probably wouldn't be in this problem, because health authorities globally, I mean the WHO especially, have published, they've really advertised. I've seen some really good science communication in the last 5 years now. It's a bit scary. And so there's been factual communication in multiple channels. But there are two psychological reasons why this still isn't enough. So first, we know that misinformation, once it's been heard, is really hard to dislodge from our minds. So even when we're told that a myth isn't true, we have this tendency to forget it over time. Debunking the misinformation leaves a gap in our brain, and that myth very easily sinks back in to fill up that gap. Now, second, there are some deeper reasons why people won't just accept facts that we tell them. And this is what's driving some very striking political patterns around vaccination rates. So this graph is about to become a bit out of date, because it's about the last US elections, not the one that's just gone. And it was mapping states that voted for Trump versus Joe Biden. And you could see COVID-19 vaccine hesitancy falling very much along those partisan lines. So this isn't an informational issue. It's got to do with trust, and it's got to do with belief systems. It goes deeper than that. And so I start there to show the space that we're working with. And it's because of all of these difficulties in countering misinformation that in JitsuVax, we developed a framework for dealing with misconceptions about vaccines that people have, because these are often fueled by misinformation. So this framework, we call it the Empathetic Refutational Interview. It's a bit of a mouthful, so I often refer to it as the ERI for short. And it's designed to help structure a conversation about vaccines. And underlying it are two foundational principles. So first, it's rooted in empathy as a way to connect with people and build trust. And we've just had a whole presentation about why that trust is important. We have even spoken a bit about in the discussion about that relationship. And we know from decades of research that trust is actually one of the strongest predictors of whether people will get vaccinated. And to get at the roots of misinformation beliefs, we do need to have these conversations. So I was talking about empathy and why it's really important as the foundation of this framework, because we want to build trust, and also because where these conversations take place are usually with health professionals, and these are usually the most trusted advisors for a lot of people when it comes to vaccination. We know from our work with healthcare professionals that they really value trust and want to maintain it with their patients, with their service users, sometimes at the expense of having conversations that they fear will be confrontational. Our second foundation principle is to work with people's attitude roots. So this is a psychological concept that I will explain in a bit more detail, because to understand it, you try and imagine that you might be hearing people expressing concerns about vaccination. I've given you a selection here that comes from our research, and most people in my audiences have come across at least 3 of them, if not all. Now, what we find with these concerns is that similar concerns tend to have common roots. And if you imagine those concerns as leaves on a tree, just as leaves are nourished and sustained by the roots of the tree, specific concerns are also sustained by attitude roots. So these are psychological motivators that are driving people to hold a particular concern. So as an example, on the left side of the screen, you've got a set of concerns that are to do with fears of suffering adverse consequences from medical treatment. But on the right side, you can see the attitude root is actually very different. I'll give you 2 seconds to guess what this is. And hopefully you all guessed right, this is a tendency to believe in conspiracy theories. So that's the foundations of our ERI framework. And we built on that foundation to develop 4 components, the little 4 steps you see at the top of the screen. And each of these components drew from a very wide background of research that comes from different disciplines. Importantly, they each have clear conversation goals and procedures that makes it easier to teach these techniques to healthcare professionals who will be our intermediaries when it comes to having conversations about vaccines. And so in the rest of my talk, I'm actually going to walk through these steps very briefly, and then I'll speak a bit about the evidence we gathered for the framework as a whole and for its implementation with healthcare professionals. So our ERI starts with 2 steps that we call eliciting concerns and affirming the individual. And these draw from the counseling technique called motivational interviewing. So this is something that I'm sure a lot of you in this room will have heard of before. But basically the idea is to try and build rapport when you just even open the conversation, even when someone has said something that you feel is completely wrong. And it's a good way to try and understand a bit more, try and identify what is driving this concern, this particular belief, and then demonstrate we understand and we're aligned to that attitude root. So this is the part that we call affirmation, which is validating and acknowledging that there's a reason why an individual has their belief, even if we don't agree with the belief themselves. So, for example, in this cartoon, the healthcare professional is telling the lady that actually she does make a good point. You do overuse some medicines, so you could see, even though it's not the case that we're overusing vaccines, you can see why that lady's reached that conclusion. So the idea here is before you even start to engage in that misinformation, try and correct the false beliefs, we need to build a bridge so that we're still always starting from a place of trust before we get into any sorts of corrections. And when it does then come to the correction part of the conversation, we're bringing in some best practices in cognitive science here. So I spoke before about how a myth tends to sink back into our brains. So using this, you might remember this little figure there. Now in cognitive science, we have studied a lot about how to get around cognitive barriers. And there are some techniques that help to replace erroneous beliefs and make corrections stick. So replacing that gap that we've created by saying, no, that myth is wrong, coming up with a plausible new narrative to fill in that gap so people remember the new information. And so we're applying these in the next 2 steps of the ERI, incorporating cognitive science to try and evoke those conceptual changes. So it's important for us to still have this correction step because that's removing any sticky blocks we have against with those misinformed beliefs, because they tend to appeal to our attitude roots and then prevent us to really engage with the facts and the evidence. And so that all happens before we finally end on providing facts, benefits of vaccination, which we also know are very effective when people are ready to engage with them. So that's our framework. And of course, our next steps were to assess how it actually functions in practice. So what I'm going to do now is to summarize a series of experimental studies we've done to test this framework. And we start with the lab, working directly with participants who are hesitant about vaccines to see how they like this approach, how they respond to it, how their views change with it. And then I'll move on to field studies where we trained healthcare professionals in the ERI for them to then have discussions with vaccine hesitant patients. Now, we've implemented this in 4 countries with over 200 healthcare professionals now, but just a preview, I will show just one study where we did a follow-up with patients there. So starting with our lab studies, I'll just explain the general design where we'd have vaccine hesitant patients view a scenario between a doctor and a patient, and the patient will bring up an argument against vaccination and the doctor will respond to this. Now, we of course always have a control condition where the doctor is very factual, talking about the safety and efficacy of the vaccination. And I should note that this is the approach that a lot of our healthcare professionals go in with, and we know this from a lot of interviews that we've done with them. Now, we of course want to test the ERI condition where the doctor is using this approach to respond to what the patient has brought up. Sometimes we also add a third condition, allowing us to compare a different sort of approach, for example, just going in correcting without any of that trust building, or just using a motivational interviewing. And then our participants would rate the doctor in their response. We also measured things like vaccine willingness, vaccine attitudes to look at some changes. And so people would rate doctors and the conversation on that 7-point scale you see with I'm adding colors so it's easier to see the results that I present. Here I'm just showing one of the ratings we got in one of the experiment. Most of our results are quite similar to this. And so remember, we targeted hesitant participants. So it's not too shocking, hopefully, that the control group had a very low baseline rating. It was sort of between the 2 and the 3, and you can see in the red the proportion of people who are not very receptive to this sort of factual approach. In this particular experiment, we first looked at whether just directly correcting misinformation helped, and it did a bit. You could see that shift a little bit, and there's a little bit more green in that figure. But we get the most support from participants when you see the doctor using the ERI approach. As you can see, the difference is kind of making that vaccine hesitant participant move a little bit more on the fence on average, but also more receptive to the information overall. And here I'm going to summarize another 2 sets of results where our third condition was comparing with the motivational interview approach. And this is actually conducted at Erfurt by our PhD student, Friederike Taubert, who I think I saw in this room. So just a shout out to her for this excellent study. It's probably no surprise because they measured trust in the physician in this scenario. And both the ERI and the motivational interviewing approach got more ratings of trust from participants. But the team also measured participants' intentions to vaccinate a child if they had one. And here we can see that the approach with the ERI was significantly outperforming the other 2 approaches. So I'll move on now to my final few minutes to the field tests, which were done in Romania by another brilliant team over there. And they managed to organize 3 groups of health practices, 1 control group that didn't get any training, 1 group that received training in the ERI, and 1 group that was receiving training in motivational interviewing. And after that training, all the GPs had, in the practices, had vaccine conversations with hesitant patients. They call them counseling sessions there. And the patients filled in questionnaires before and after the conversation, so we could actually measure changes in their attitudes. And so looking at the results, this first is vaccine attitudes. So the graph shows the change before and after the conversation the patients had with the GPs. And we saw the most positive change in attitudes with the GPs that were trained in the ERI. And this was actually similar for patients' willingness to have vaccine. This was obviously a measure of their intentions to be vaccinated. Now, finally, what was interesting in this study was that we could also see the number of vaccine appointments booked immediately after the consultation. And we could see that compared to the control condition, the number of bookings were definitely higher in both the ERI and the motivational interviewing trained practices. So it's approximately 10 to 20% higher. And so we're seeing some translation into behavior here. So to sum up, we found that our studies in the lab, the ERI produced the most support, a lot of trust, openness, better intentions to vaccinate than other approaches we tested it against. And in the field, we were able to increase skills and confidence of healthcare professionals who then carried that successfully into their conversations with vaccine hesitant patients. And so we believe that this approach, which already builds on a lot of earlier work and directly adds skills to refute misinformation, is for us a promising tool for healthcare professionals to frame their conversations in a way that can increase vaccine acceptance, but still maintain that trust that is important to them and important when we're looking at improving health services and health equity. So I'll end here now and say a big thank you to the rest of the JITSUVAX team, and hopefully we can have more of a conversation about vaccination and misinformation. Thank you.
Thank you so much, Dawn, for this fantastic and dense talk and a fantastic timing. So we have a couple of minutes left for questions, feedback, thoughts to be shared and discussed. Robert Böhm, please go ahead.
Thanks so much, Dawn. I of course have read the papers beforehand, so I like that a lot, this approach. I think it's a really nice approach and the data speaks for it. I'm wondering whether you have already thought about or maybe even tested the opportunity to implement that with generative AI, because this appears like such a straightforward, rule-based way of how to engage in an interaction that it should be fairly simple to train a generative AI, which of course helps to scale up the method to use it as a chatbot on healthcare websites, for instance. So any thoughts or ideas or maybe already data in this direction?
So it's something that we've definitely discussed in our lab. But one reservation I have is people's willingness to come to that. So here's the thing. So we do know that from some studies that have looked into conspiracy theories and generative AI, that they're able to get people who really believe in conspiracies to sort of critically think and reduce their conspiracy beliefs. That wasn't directly with vaccination. However, one of the challenges we have is actually even getting that conversation started. So one of the reasons why we work with healthcare professionals is because they have, they are in a position where they can actually initiate those conversations, and they already belong to a position of trust. It may not be health professionals necessarily. We have been talking and working with community ambassadors as well. So places where trust already exists. And so I suppose I was a bit on the fence about this, about whether people will willingly engage with a web chatbot, and it will have the same effect, because I'm not sure that chatbot starts from the same position of trust. On the other hand, compared with, say, a physician who might not have the best manner, then perhaps that would actually work. But of course, I don't really have any data to actually compare. So my thought would be that, obviously this is my judgment rather than any empirically driven answer. My thoughts are that a physician using this well will have a better impact than a chatbot, and a chatbot would be better than a physician who is not having a good conversation.
Yeah, I think you mentioned an important thing about like the trust relationship. But imagine there's someone who's like, I mean, typically with vaccine communication, we do not try even to target those who are really strong skeptics, right? So there needs to be at least some trust relationship. Imagine those people, they may actually have a higher level of trust towards a neutral AI than towards a doctor, right? So it's a matter of, but anyway, so actually we got a grant doing such kind of stuff. Maybe we can collaborate on that in the future. I would really like to try your approach using generative AI. I think it's a fantastic tool. Thanks so much for the presentation.
Yeah, let's talk further. Thank you.
Well, that sounds great. So one goal we have already accomplished, bring together people to do cool things. And so we have one more person in the chat, Maria, would like to pose a question.
Hi.
Maybe quick question, quick answer.
Basically, so I'm not an expert in the field, I'm here to learn. But what I've been listening to and what I've been hearing is how, if you have a chatbot, people want to establish trust and establish a relationship, and we talked about empathy throughout. How can one develop empathy and trust, I mean, with a chatbot? I have difficulty with understanding this, because I still think that people want people. I know maybe in some cases it might work, but I'm not convinced.
Yeah, it's a very fascinating area, because I think sometimes we think of chatbots like, you know, those really annoying ones that you go to when you're trying to access tax services and it just keeps looping you around. So when you think of chatbots in that way, it is quite hard to imagine developing a rapport and a relationship. But there are some really advanced ones as well. And one that you can look into actually is relationship chatbots, where you design your own sort of ideal romantic partner, and people have really actually developed sort of, I don't think it's parasocial, but I can't remember the word for it. It's just a very deep connection, to the point that when the companies decided, oh right, we'll put some safeguards and tweaked it, they felt as though they had lost a real partner. So it is actually possible for people over time, over interactions with advanced technology to develop that sort of relationship. And so it's quite an interesting, sometimes scary frontier. Yeah, I hope that answers the question.
Yeah, so there are very interesting things to come and to discuss in further meetings. So thank you very much, Dawn. I think it's also time for flowers. Here they are. So thank you so much for your talk and the insights on JITSUVAX. And to introduce our next speaker, Robert Böhm, I'll hand over to Lars Korn, who is also at the Bernhard Nocht Institute for Tropical Medicine. Well, Lars, please go ahead.
Thank you. So I have the honor to introduce our third speaker, Professor Robert Böhm, who will talk about antimicrobial resistance as a social dilemma. He holds currently a professorship of social psychology with a focus on judgment and decision making and pro-social behavior to address global challenges at the University of Vienna. He had former positions at the University of Copenhagen and the RWTH Aachen, and he was also a postdoc at the University of Erfurt. Currently, he is the head of the Social and Economic Psychology Group at the Department of Occupational, Economic and Social Psychology at the University of Vienna, and most importantly, I guess for our audience today, he is the director of the new WHO Collaboration Center on Social and Behavioral Research in Microbial Resistance. So with this, I want to hand over to you, Robert. The stage is yours.
Okay, thank you so much. Can you see my slides?
Yes, we can.
Okay, before I get started, just as a response to this, whether you can really feel empathy from a chatbot, there's actually, it depends on what is the comparison. So there is actually some pretty good studies out there that show that doctors, on average, GPs, do not have a very high level of empathy. And if they do not get such a great training as we have just seen, actually, even standard generative AI can communicate with a higher level of empathy. Yeah, just saying that. But of course, the question is then whether it would still be better than after doctors receive such great training. Okay, but this is not the topic of my talks. I'm very grateful to be invited to the symposium. Thank you, Sarah. Thank you, Cornelia. And I'm going to talk, I was asked to talk a little bit about antimicrobial resistance with a special focus on the social dilemma perspective underlying this problem. And let me get started by introducing you the story of Vanessa Carter. So Vanessa she's from South Africa. She had a car accident when she was 25. That led to several severe face reconstruction surgeries. At some point, so this took several years, she got infected with MRSA. This is one of the most common bacterial strains that is largely resistant to antibiotics. So she fought with MRSA for actually 3 years before she eventually won this battle and the infection cleared. So eventually, it wasn't the injuries from the car crash itself, but the drug-resistant infection that became the biggest threat to her life. So Vanessa is now a so-called AMR survivor. She became an activist and communicator. It's very inspiring to listen to her. You can check out her videos online. She's the founder of the AMR Narrative Initiative and the chair of the WHO task force of AMR survivors. So why I started with this story is to make clear that actually AMR is not something that may happen in the distant future, but it's a threat that we are witnessing now at the moment, and it's even increasing. So as WHO already wrote 10 years ago, AMR poses a serious threat that is no longer a prediction for the future. It's happening right now in every region of the world and has the potential to affect anyone of any age and in any country. So at the moment in the WHO European region, AMR is directly responsible for more than 100,000 deaths each year. And this number is going to increase dramatically. So there has been just recently a new publication which estimated that worldwide there will be 39 million people likely die from drug-resistant infections between now and 2050. So these are rising numbers. It's a huge threat. And so the first question maybe to address that is, well, what can we do against this increasing threat? Well, it is important to understand that although AMR reflects a very natural evolutionary process of selection pressures that are happening on, for instance, bacteria, but also fungi, but this takes place, during every contact with bacterial strains with antibiotics, for instance, in both animals and humans, but it is eventually human behaviors that may accelerate this natural process. And this makes this threat so complicated. There are several of our behaviors that are related to it. It's not only about mis- and overuse of antibiotics, so overprescription, so doctors prescribing antibiotics when it's not appropriate, or that patients don't take it as prescribed or directed, but it's also clearly related to poor hygiene, infection, prevention, and control, particularly in countries where this is not on such a level as in Western Europe. But it's also related to lack of vaccine uptake, which there are some vaccines that protect against bacterial infections. It's also related to extensive traveling, which may spread drug-resistant bacteria, or to consumption of certain kind of products, for instance, from mass animal farming that may, where antibiotics are used massively. So this makes it, on the one hand, very threatening because there are so many behaviors related to it. But as a scientist, I have also to say that it's kind of exciting because it's one of the most complicated behavioral problems I'm aware of. Yeah. So, but if we now know that list, and this is not an extensive list, there are even more factors contributing to it, we could just say, well, we just simply address each and every of those behaviors. Yeah. But why is this so difficult? Why, even if we communicate about it, may some people, even if they know about the dangers related to AMR and the increasing threat coming from it, why may it be so difficult to lead to a behavioral change? Well, one problem is that the costs of behavior change are typically at least perceived as personal costs, right? So you need to spend more effort to keep hygiene high, to get vaccinated, or to follow certain kind of antibiotic direction when taking in antibiotics. But the benefits are typically on a societal level. You don't really experience the benefits, but you experience the costs. The costs are short-term. They happen now. If you are ill, just wait a few days before you start antibiotic therapy, whereas the benefits may be long-term, right? So as it is accelerating. The costs are to our own healthcare system. So this is a different level of conflict now. It's in our countries that we need to invest more to stop this accelerating threat. But the benefits are also to other countries, particularly to low and middle income countries. And of course, this is a complex problem. I didn't even try to explain you the biology behind it. It's a pretty complex thing. And people, if they don't understand it, they rather avoid engaging with it and thinking about it in the first place. So AMR-related behaviors, including antibiotic use, but not limited to it, pose a multi-level social dilemmas because exactly of those like opposing forces that work there. So there are conflicting interests between individuals and societal outcomes on the one hand, but it's even multi-level because there are also conflicting interests between different groups. So between high-income countries and low-income countries, or between the current generation and the future generation, as due to the delayed consequences, it will be mainly our children and grandchildren who will suffer from the increasing AMR threat. So this underlying social dilemma structure poses, of course, a huge challenge to the communication about AMR. But what I want to show you a few examples for is that it may also provide new opportunities how to communicate about it and related behavioral interventions. So in addition to the necessary policy changes, behavioral interventions should actually address this social dilemma structure to change AMR-related behaviors. And I want to give you a few examples from our own lab, and actually this is done with Cornelia and her group over the last years, where we try to specifically tackle the social dilemma aspect of AMR. So one idea is, as this is now becomes a cooperation problem, a problem where it's the question whether I want to only follow my self-interest or follow societal collective interest. Well, we know in reality that people are more likely to cooperate if we provide information about others' behaviors. Because first of all, you may be judged by others. Yeah, you see others behaving in a certain way, but you also may judge others. So just providing full information about, for instance, antibiotic use may help to increase pro-social concerns. And this is what we tested in one study where we developed a behavioral game that mirrors the social dilemma consequences. I spare you with the details about that. But what you see here is basically that there are two conditions, one where people are faced with a severe disease and one with a mild disease. And in the severe disease, it is rational and collectively efficient to take antibiotics. You should take it. But in the case of a mild disease, you should not take it in this particular dilemma as we explained it to our participants. And what you see is that if we don't provide social information, so if this kind of information about other people's intake in this game is absent, you see that they're spread over different types of behavior. Some people take antibiotics, others don't. And now if we just provide information about others' intake, which is a very minor, very low-level intervention, you see that the distribution shifts a little bit in the direction that people are less willing to take antibiotics if it's not really needed. This is not a major shift, yeah? I'm not showing you data where we change all people's kind of behavior, but I'm showing you a very simple intervention that may at least lead to a slight change. Another idea is, as I said before, that you need to explain in the first place people the pro-social nature of their behaviors. So you need to make them aware that other people may suffer. And there are many real-life interventions like that. The UK is a leading country in the efforts in regarding AMR, and they have quite a few cool videos out there, for instance, by the UK Antibiotic Guardian campaign, where they explain stories like I showed you from Vanessa Carter of people that suffered from AMR. And we again played a game where, first of all, the consequences were relevant for the own generation of players. So what we call an intra-generational conflict. And you see that there's some intake. However, this intake increases dramatically if the consequences are delayed and address a future generation. So people are more likely to follow their self-interest if the negative consequences of AMR have to be taken by the future generation. But if we now presented such kind of an empathy eliciting video, which is exactly derived from what has been done in the UK Antibiotic Guardian campaign, we find that we can again reduce those overuse of antibiotics. So explaining people the negative future consequences may help to reduce overuse. And the last idea is, well, this is all about explanation, right? You hope that people understand if you show them some videos, But the main problem is that they can oftentimes, or not oftentimes, always, we cannot zoom in the future and experience how will a world look like in 50 or 100 years from now when there are higher levels of AMR. Well, new technologies like virtual reality allow actually that people can make personal experience in a distant future. And we tried that. So we developed an immersive game where people could experience, if they repeatedly and the society in general overuses antibiotics, how will the future look like when antibiotics are resistant, or when bacteria are resistant to antibiotics. And what we do find is that indeed in the experience condition, this is the yellow one, you find that so this is baseline intake at the beginning, and then after the intervention, if people can make an experiential learning experience, they are more likely to increase their intentions in the future, to be more prudent in their intake. And we measured this again 1 week later, and we found that it remained on the highest level. So a very short virtual reality intervention can help people to feel the consequences. And this seems, at least for 1 week, to be stable. So let me give you a few concluding thoughts and remarks. So the most important message here is that the accelerated threat of AMR is fundamentally a behavioral issue. This is very important to understand in our efforts to overcome it. A social dilemma perspective, as I have just tried to explain here, may help to rethink and also develop behavioral interventions aimed at changing AMR-related behaviors. In this context, we frame AMR-related behaviors as pro-social actions, and we know that as human beings, we are very willing to act pro-socially towards others. However, we need a more systematic and holistic research program to help people better understand the threat of AMR, the behaviors that relate to it, and how they can personally contribute to mitigating the spread of AMR. And related to that, we also need to develop a toolbox of AMR-related behavior change interventions. This may include, but is of course not limited to, those interventions that address pro-social concerns. Because if we have a toolbox of different types of interventions, then we can target different behaviors and can also tailor to different population groups. However, I mean, we are standing just at the beginning. Such efforts require large-scale cross-country inter- and transdisciplinary collaborations. And this is also an invitation to all of you to contribute to such future efforts. Thank you very much again for the invitation, and happy birthday, Bride, to your very first birthday.
So, okay, I will take a look. So thank you for your presentation. I will look whether the chat has some questions. No. Maybe I give the audience some time to raise their hands, and I will ask you a question. I'm really interested in the VR aspect of AMR interventions. And you showed some pictures of people wearing these glasses. How is it really practical to do it, for example, in a physician center, or where do you think we could implement those interventions?
Yeah, that's the very first question that we always receive when we discuss and present such kind of VR experiments. And I think there are several answers to it. First of all, there will be a huge increase, a much stronger penetration of VR headsets in the next years. I have to say that we are a little bit behind expectations, because already 5 years ago, they said that all of us will basically have such a headset, and it is increasing dramatically, but I'm not sure how many people of you have a headset at home. So it's going a little bit slower than anticipated, yeah? But the assumption is that in the future, we will attend meetings like that via VR headsets. We will consume media via such headsets, because it's a much cooler experience if you feel you are immersed. Imagine all of us would have the feeling we are sitting in the same room. And this is possible nowadays, yeah? Just at least universities are not willing to spend the money for this technology. However, what we believe, what might be a lower level entry for health communication is, as you mentioned already, Lars, use it in GP waiting rooms, right? So a GP can afford 1 or 2 set of glasses, and then with maybe certified, maybe WHO or governmental certified interventions, people could be prepared before they engage in the interaction with a doctor. We are also not claiming that those kind of interventions should replace patient-doctor interactions, but they may repair them or prepare them. Maybe also repair, but mainly prepare. Yeah, so they should help to maybe put a lot of some information already out there, and then they may have much more specific question, because the main problem, of course, of GPs is that they barely have the time to engage with patients who are skeptical, for instance, or don't want to have an antibiotic now. Yeah, so this is one idea. But what we also consider is, as a practical device, is using this in schools, right? So I believe health communication should happen in every school, be it hygiene things, but also vaccination, AMR. I think like climate change, these are all things that need to be communicated in schools. And schools should use measures to communicate things properly and appropriately. Yeah? And nowadays, this also includes immersive technologies.
Thank you. So I've got a question from the chat from Franziska Oeschger. In the beginning, you showed that behavior of various actors impacts AMR. Are you also looking at other actors, for example, farmers or policymakers?
Yes, so in what I presented here, not. Yeah, there we care about patient preferences. But yes, in the future, and with this new WHO collaborating center, we also plan to involve other stakeholders, because it is a multi-stakeholder problem. Yeah, and the first thing is, and we have some first studies working with GPs, the question of how can we reduce overprescribing. And of course, what we also want to start now is to engage more in the agricultural sector. There, the problem may be, there may be completely different kind of incentives, right, related there. I mean, it may be that your whole future financial security depends on giving antibiotics to animals. Yeah. So at the moment, we so far in the previous years, we have focused mainly on patient, but in the future, we want to extend step by step to include all stakeholders. Yes, it's a very important thing.
Thank you. And now we have a question from Nils Fiedje.
Thank you very much. And thanks, Holford, for, as always, a great presentation. It was really fantastic to listen to. I have one question about one of your latter slides. I think you were talking about the possible importance of connecting to empathy via kind of narrative approaches, I guess. And I think there is more and more evidence to show how the stickiness of empathy kind of promotes more effective behavior change. But the problem with connecting to empathy is that it's really difficult to do. I imagine it's really difficult to create those narratives well. So on the one hand, it's easy to recommend. But on the other hand, it's really difficult to do. And I'm wondering if you've got any ideas about, how do we improve the quality of connecting to empathy through narrative approaches?
Yeah, that's an important question, because this is one of the areas where kind of research and practice deviate quite a bit. So there is a decade-long research history in social psychology using different types of empathy manipulations. And this starts from very simple text-based interventions, starting with think about what a person may feel, something like that. And then write it down maybe in 2 or 3 bullet points. And many of the studies, actually dozens of the studies conducted in this area, use such type of intervention. And you can imagine that this is such a poor intervention. It may work to change in a lab-based environment to shift from on a 7-point scale from 5 to 5.5, but in reality, it may probably not lead to a big change. And this is also why in this particular study that I showed you, we relied on the message on a more narrative way of doing it that was created by the UK Antibiotic Guardian campaign, because they do a pretty good job in making this really close, what people have suffered from AMR, some narratives. So I believe a strong key is working with narratives. But of course, then this comes also with a cost because narratives take more time, right? So you need to have a motivation in the first place to follow. And there we then deal with problems like information avoidance, for instance, which we also study, that people, if they know it's dealing about a negative thing, about some negative prospects in the future, people rather prefer to not engage with the communication materials at all. So this is an open challenge, I would say. Yeah, I think we can create very strong empathy if we use video materials, interactive materials, or even immersive manipulations. But the question is, how do we get people in such interactions or to such materials to engage with it in the first place? And this is not so easy. I fully agree.
Thank you for the great questions, and thank you for your presentation, Robert. We have to move on, and I will, hand over to Sarah.
And we will also share again the flowers. Thank you very much, Robert, and also from my side for a fantastic presentation. And I now look forward to introduce Katrine Habersaat from the WHO Regional Office for Europe and Copenhagen. She leads the Behavior and Culture Insights unit at WHO Euro, and I think she's the most, the person with the highest ability that I've ever met to turn research into practice. If you give her some research outcomes, she has an idea of what to do with it. So I'm really, really happy that she is at this very important position at WHO and putting forward this idea that we need more behavior research and more behavior insights and cultural insights, which she has very much let the cultural part also added to this BCI work at WHO. So I'm very grateful that she's in this position, leading the work in WHO, which is also where the WHO European region, I think, is also a leading region in this work. And this is all thanks to Katrine and her team. And so thank you very much for being here and showing us what behavior insights and culture insights can do in the European region. Well, very welcome, Katrine.
Thank you, Cornelia. Thank you, Connie, for that warm praise. I'm very, very happy. Thank you. Let me share my presentation first. And then I hope you can all see it. Okay. Yes.
Yeah, fantastic.
All right. Okay. So first of all, thank you for inviting me, and a warm congratulations on your 1-year birthday at Bright. I am really, really very pleased that 1 year ago we were able to designate your group as a collaborating center. We've worked together for many, many years, and I think it was just about time that this fruitful collaboration was formalized. The Bright Center and all of you here are helping us at WHO Europe to apply behavioral science methodologies to real health challenges that are faced by WHO's member states. I was asked at the tail end of this webinar to share a bit about the BCI unit, how we work with collaborating centers and academics. And I was thinking it's late in the day and it's probably the first day back to work for many of you. So I thought, okay, I have a video with a little bit of a kick in it, and it's a nice introduction to the team as well. So I will show you the video, and then I'll go ahead with some examples of how we work with collaborating centers afterwards.
Public health today is faced with extensive challenges. Cancer, hypertension, epidemics, antimicrobial resistance, the health impacts of climate change, and rising mental health challenges. More than ever, we need innovative, effective, and people-centered approaches. Using behavioral and cultural insights to inform health policies, health services, and health communications offers such an opportunity.
Behaviors are at the heart of most challenges facing public health today. What we eat and drink, how much we exercise, whether we vaccinate or whether we keep to a full course of antibiotics. These are all examples of important health behaviors that are grounded in complex, individual, and social contexts.
Behavioral and Cultural Insights, or BCI, brings together robust methods and evidence to respond to these challenges. BCI can be used by public health authorities to understand health behaviors, the context in which they take place, and how to address the barriers people experience. As examples, such insights have been used to increase vaccine uptake for addressing community-specific barriers and to increase equal access to care through intercultural mediation.
Testing if interventions work, as well as when, for whom, and why, is central to BCI. For example, through rigorous evaluation, we know that letters providing social norm feedback to doctors who prescribe more antibiotics than their peers can reduce unnecessary antibiotic prescribing. It has also been documented that labels designed with the use of behavioral science can change our ways and habits for buying healthier food.
It was a milestone event when all member states of the WHO European region in September 2022 unanimously adopted a regional resolution and 5-year plan for behavioral and cultural insights for health. This was followed by a global resolution in May 2023. In line with the spirit of these documents, WHO Regional Office for Europe established a community of practice with representatives of public health authorities from member states of the region.
The 5 strategic commitments made by member states: to build support among stakeholders, to conduct BCI research, and to use what we learn to improve outcomes of health-related policies, services, and communications, to commit human and financial resources, and to implement strategic plans. These are ambitious commitments, but if we collaborate and share, and if we invest in this field, we can, and we will, make them come true together.
So that was introduction to some of our work and our team. Clearly, behaviors are essential to health. We've heard that from several presenters here today, and we think this fundamental role of behaviors in health points to a need to enable, to support, to promote, to sometimes restrict health-related behaviors through strategies that are effective and evidence-based, as well as, importantly, culturally informed. And as we said in the video, when we talk about BCI, behavioral and cultural insights, it's about systematically exploring the factors that affect health behaviors using both global and local insights and evidence, and then using that evidence to strengthen the health policies, services, and communications that target health behaviors, and evaluating the documented impact of these interventions on behaviors as well as on health outcomes. And the factors we want to explore can be both individual
and contextual, so they can relate to individual knowledge, perceptions, motivations, trust. But of course, they can also relate to the broader cultural context, to social norms and structures, and of course, to the access legislation structures related to the behavior. And this approach really addresses, and we've heard that here today as well, sometimes very, very complex issues. And so for that reason, we encourage interdisciplinary methods, and we value participatory and people-centered approaches. We have a mission of advancing the use of behavioral and cultural insights for health across the region, and we do that through a number of work streams informed by our resolution and the 5-year action plan that we mentioned in the video. We engage in in-country projects targeting specific behaviors in specific population groups. We organize a lot of different capacity building and training opportunities through in-country, online, and regional training and strategy opportunities. We engage in partnership and advocacy, most importantly through our community of practice with officially nominated focal points from all of the countries in the region. We meet with them very regularly, and I even saw a few of them here today. And of course, evidence generation, evidence dissemination, which we do in close collaboration with our collaborating centers and academic institutions. And as you can see, we work with academic institutions and our collaborating centers across the board, across these different strategic work streams. We work together on literature reviews, the synthesis, various research studies or evaluations, the trainings, and the development of both guidance and policy considerations. And as such, our growing network of collaborating centers really are the engine room powering us to work beyond our capacities and means. And they are really very important. They play a vital role in helping us not support member states, not just with frameworks or toolkits, but also with insights and action. And I'm just going to share a few brief examples, and I will start with our hosts here today. And as I mentioned, even before you became a collaborating center, we've worked together for many years, including on an annual summer school, and then, of course, with a massive endeavor during the pandemic that Sarah also mentioned at the beginning. At the beginning of the pandemic, Bernhard Nocht and the University of Erfurt had developed a country survey on COVID-19 for use in Germany, and they gracefully allowed us to develop this into a generic tool and offer it for use across countries. And I think we were all surprised to see that there was such a huge interest, and 30 countries within our region and many countries beyond used the tool and collected several rounds of data throughout the pandemic. And 18 of these countries in our region were lower middle income countries that needed hands-on support. And so we worked very closely with Sarah Eitze and Philipp Sprengholz and Cornelia Betsch and a number of other colleagues for data analysis, for reporting month after month after month. It was really an example of very concrete in-country work where we benefited immensely from our generous and free support. Another example we already heard from Felicity is the Collaborating Center on Culture and Health at the University of Exeter, where really that was a center that was designated already in 2016. And during this time, Felicity Thomas and others have been instrumental in helping us develop a number of outputs, including the 2 publications you see here. And these publications and her work and the work of the center really helped us shape how we work with culture in the unit. And the next project we're embarking on with them and others is a paper and normative guidance on the role of culture in behaviors, so really central to our work. We've also heard from Robert Böhm already, the Collaborating Center, brand new Collaborating Center on Social and Behavioral Research in Antimicrobial Resistance with the University of Vienna. We have several projects underway, including a project that aims to understand and produce guidance on how to communicate about antimicrobial resistance with the general public in a way that is more understandable and which motivates appropriate antibiotic use and behaviors in a way
that we're not able to do today because it's so complex, it's so technical, and we're just using words that people don't understand. There's another project underway to evaluate the impact of a leaflet to help reduce inappropriate prescriptions among health workers. And the last quick example I wanted to highlight is an upcoming collaborating center with Aston University, where we are exploring, expanding on, and disseminating evidence related to public support for health policies. We know that health policies are less effective if they are not supported by the general public. And despite this fact, how to best measure and maximize public support for health policies is today largely an underexplored area of research and implementation. And we want to address that gap in this collaboration. And then I just want to mention that we also have a technical advisory group with experts on behavioral and cultural insights, and some of the collaborating center representatives have been represented here, including Cornelia Betsch and Felicity Thomas and Robert Böhm that you've heard from today, and others as well. And we meet at least once a year with our group to discuss how the use of BCI for health can be advanced across the region and how the current evidence can be used to support our work. These were just a few highlights of our work with collaborating centers and academics. As you can tell, we really benefit enormously from this generous support of academic institutions in our work. And I think we're at a critical juncture in public health with massive challenges, but also with opportunities. And with this incredible support from collaborating centers like those of you who are here today, I am confident that we can change how we across the board understand and address behaviors in health. And I'm going to stop here.
Thank you so much, Katrine, for these insights. It's always very inspiring to see how broad the area of work is that you do, and to see all the familiar faces. And it's also very nice to see those collaborating centers. And it's very, I think it's interesting also to meet with these collaborating centers, because all the topics you mentioned, I know would be interesting to many of us. So it's really great that we have the opportunity to meet and to exchange thoughts. So I would just briefly open this also to the audience. If you want to have a comment, a question to Katrine or the BCI team, you would now have the chance. Okay, maybe I can, is there in the chat? No, we don't have a question in the chat. I think this was also very comprehensive. We all now are very keen on seeing how the new program of work is going to develop. So the topics we saw are very interesting. And I think a lot of what we saw today, I mean, we came a long way, right? From AI to personal relationships. And I think what we really saw in all the talks and the discussion is that what people think and feel and whom they trust is very central to many of the health problems. And and especially in this interconnected world and the rapidly changing world. And so I think your talk also very nicely showed that behavioral change, or understanding behavior to change behavior, which was one of the mottos of Behavioral Insight Summer Schools, is a very central building block. It'll not do the trick alone, certainly not, but it's a very important building block. And I'm very grateful that WHO has such a strong area of work to look into this. So thank you very much to WHO. Thank you very much to all the speakers. And I would like to hand over to Sarah to say some final words. So thanks from my side and goodbye. Sarah.
So last but not least, there's a last bunch of flowers, of course, for Katrine as well. And Then I'd just like to say thank you all for participating, for your talks, for your questions, for the discussion. I think from the chat we see that concerning AI and trust, there's more to talk about. Thank you for being part of our first birthday party. And if there's anything left that you would like to tell us without the audience being present or being recorded, you can also write us at any time, an email at bright@bnetm.de. And with that, we can just say farewell and see you soon from us and the whole team. Thank you. That's all.
Thank you and goodbye, everyone. And thanks again to the speakers.
Thank you all. Bye-bye.